If you look at women who get treated for their ovary cancer at a tertiary care center, a high volume center where they see a lot of ovary cancer, those patients, forget HIPEC, do better than patients that go to the community hospital to get treated or go to somebody who's, oh, I do 6 of these a year. So now let's add more complexity with giving chemotherapy in the operating room, do extensive radical surgery, because without the radical surgery, the HIPEC is meaningless. So, of course, these people probably should only be done in tertiary care centers. I'm not bad-mouthing community hospitals. There are some that have, I'm sure, a very excellent reputation and high volume, but you need to be in a tertiary care center. You need to be in a high-volume center. I would not endorse doing this, any which way, because, you need that experience so that your patients do well. In terms of randomized controlled data, another thing to consider is how many of us take patients to the operating room with recurrent ovary cancer and debulk them prior to giving chemo. How many randomized controlled trials have been done that have shown a benefit to that? Exactly 0. Yet many of us do it and believe it. This is actually, to me, pretty amazing that we have a randomized trial where we take people to the operating room and randomly assign them a HIPEC, and HIPEC is better. So, again, for the critics out there, point to me one randomized controlled trial for debulking recurrent ovary cancer. There's not. There's a ton of work out there on retrospective, analysis, my experience, but not randomized data. Again, any trial can be criticized, period, end of story. This one happened to be pretty good. It wouldn't probably have gotten a New England Journal without it. Let's be honest. This is one trial, or 2 if you want to look at recurrent disease. It has to be interpreted with caution. I don't know that this should radically change what we do for women with ovary cancer. The data is compelling, it's interesting, and it's very exciting, especially for those of us that have a large volume of patients with advanced and recurrent ovary cancer. These are cancers that we're generally not able to cure. So if we can kick overall survival down the road, progression-free survival down the road, and then get on to new drugs and new therapies, maybe we're improving things down the line. So again, to be honest, this is exciting, but not necessarily let's do this for everybody. So with that being said, I would encourage everybody to read the paper and critically analyze it. This is not therapy for everybody. A select group of people with good patient selection, good surgical technique, I think can really benefit. So I think it's moving the needle, but it's not going to cure everybody with ovary cancer, bottom line.